So what I'm going to do now in this short talk is cover side effects, things that I think no one likes to have to see and deal with, but it's important that we do. A lot of this was covered earlier today, which will make my job a little easier. And I think we're really now at a stage in the field where 20 years ago we said, it's interesting if you read the books, that the diet had no side effects, which was clearly not true. About 10 years ago, they said, well, now we know what the side effects are, and I'll show you them. But wait until there's a problem, and then when there's a problem, then treat the problem. Whereas I think where we are now is what can we do to prevent those side effects from ever happening, so that the child will not have any trouble on the diet in an ideal world. And I think the way to probably do that, almost definitely, is supplements, giving supplements at the time of the diet. And we'll talk about what those are. When families come see us, we do spend a lot of time explaining this to them, especially in the United States and some parts from California. They think that the diet is healthy. They think that it is alternative therapy with no side effects. And we really spend a lot of time explaining to them that no, that's not true, that there are medical problems, just like it's any medical treatment. These were some review articles that were published after a case report was published. So the first one was actually after the very first case of pancreatitis was described, and the author said this has risk. This is a photograph from one of my ketogenic diet teaching sessions, and we spend a lot of time in the education during the admission week, not even necessarily teaching how to weigh and measure, but telling the families what to watch out for. What are the side effects? What are the signs of a kidney stone, for example? The families, you have to explain this to them because they may not know what it is. And so this is actually a photograph. It's my dietitian's back. That's Zahava teaching some mothers about how to do the diet and what the things to watch out for are. We tell them that there are kind of two varieties of side effects. The ones that are common, the ones that happen in most children, and these are constipation. We tell families almost everyone will get a little bit constipated. Weight loss can happen, usually not a big issue, but it can happen. Hypoglycemia, mostly just during the first week or two. We don't usually check blood glucose much after that. And then reflux is really becoming much more recognized as a problem, which we didn't realize before, and I'll talk about that. And then we tell families that there are the occasional side effects that we really have to explain to them to watch out for, because that happens maybe 5%. And those include, and we heard great examples of those here today, acidosis, especially when children get sick. Children with Dravet syndrome get a fever, they can become acidotic. Kidney stones, we'll talk about. Growth slowing, high cholesterol, hyperlipidemia. And then recently some more in the literature about selenium and carnitine, some pro, some minus about what to do about those. We know about lipids. This is probably the one that most people who don't know about the diet worry about the most. Is the child going to have a cholesterol that is extremely high? Okay, now this is sort of using US guidelines. So for normal is around 200, okay, sort of US guidelines. And you can see in orange that cholesterol usually does go up, okay, by about 50 points. But then interestingly, at 6 months, here it is, then at 12 months it comes back down, and then at 24 months it continues to stabilize. And we're seeing this as well, interestingly, in our adults who go up for maybe the first 3 to 4 months, and then they kind of drift back down to normal. Triglycerides, LDL, the same kind of thing is what we see. So sometimes we tell families initially we're going to see an increase, but then if you're patient, things get better. We decided about 2008, 2007 to look and see what our reaction was to high cholesterol. This is Dr. Nizamuddin, who was a medical student at the time and was asking me in clinic. He says, well, what do you do when the cholesterol goes up? And I said, well, I'll show you. I said, it happens a lot. I said about 60% of the time the cholesterol goes up. And I said, in general, we found, and this is what was true, that those children who were not receiving a lot of the animal fats, so those who were on the formula seemed to be doing better. I said, sometimes we do things like add MCT oil. Sometimes we look at the kind of fat and try to do polyunsaturated fats. I said sometimes we add carnitine. We've had some experience where that can help the lipid profile. I said sometimes we just watch. And so Junaid, our student, said, well, does this work? Does you using these different treatments, does it make a difference? So we decided to look, okay, and we found that 60% of the time, if we added MCT or lowered the ketogenic ratio or added carnitine, 60% of the time the cholesterol values came down. What was very interesting was if we did nothing, 41% of the time it came down. So sort of, in a way, the study showed that doing nothing is just as good as doing all these treatments. And so sometimes we see these children come to clinic, the parents find out what the cholesterol was and get very worried, and they say, doctor, what are you going to do? And I say, I'll see you in 3 months. And they don't always like that. But often when they come back, it's kind of come back down to normal. So sometimes if that doesn't happen and it's still going up, then I'll start making some interventions. Vomiting and reflux is really growing in terms of recognition around the world. The Koreans, who have done some good work with mitochondrial disorders, have done a lot of work with reflux. Some of their studies say that up to about a third of children can have very significant reflux, especially during the first few months on the diet. It often does get better. It may have something to do with just that high amount of fat. It may also have something to do with irritation of the esophagus or dysmotility. Lots of different theories about why reflux is such a problem, but we're recognizing it more and more. And a lot of our children, we talk to them about it. In 2008, they did a very interesting study where before starting the diet, they did endoscopies in all of their children in Korea. I don't know if that would have worked in America, if the parents would have agreed to that. But they did, and they found that a lot of these children on endoscopy, maybe just from having epilepsy, had signs of irritation. And that if they had those signs of irritation and then they went on the diet, you can see here 85% of them went on to have clinical signs. I'm not sure I'd recommend doing endoscopies in children before the diet, but I think it's just important to realize that this is an issue and you should talk about it. I'd probably put more children on medications like omeprazole, it's called Prilosec in the United States, Zantac or ranitidine than I've ever done before. It just seems like it's becoming more of an issue, or maybe I'm just recognizing it more. In Table 4 of our consensus statement, we started to address this issue, and there was actually a lot of debate amongst the members of the consensus group about what should be on this panel of supplements that should be given to children. The only things we agreed on, after a lot of arguments and emails and some nasty phone calls, was multivitamins, calcium, and vitamin D. Those absolutely have to be given. But you can see here all of these optional therapies, okay, and we'll talk about polycitra, laxatives like Miralax, extra selenium, vitamin D, carnitine, salt, all of these things nobody could agree on. There were a few doctors in the consensus who said absolutely everyone should get it. And I told them I think everybody should get Citric A, but most people didn't agree with me. There was a lot of interesting arguments. And so, at least right now, this is what we tell people, okay? But I'm going to talk to you about some of what the evidence would suggest for some of these other supplements. Kidney stones, if you look historically, most reviews will say they happen in 5% of children on the diet. What we had heard from our nephrologist was that if you alkalinize the urine using citrates, okay, either potassium citrates or sodium citrates, you are less likely to create kidney stones. And what we found as well was that the risk was not really much higher with topiramate or zonisamide above that 5%. One thing we used to do was we used to check the urine calcium, and if that was high, we would supplement. But we found we were missing a lot of children. Sometimes we didn't have the urine results when they'd come to clinic, and it really wasn't making much of a difference in preventing kidney stones overall. So we decided back about 2006 that we were going to put every single child on Citric A at the start of the diet twice a day, 30 milliequivalents. This is what the powder of Citric A looks like. It also comes in a liquid form. And we found when we did that, when every single child got Citric A, the risk of kidney stones went from 6% to 1%. So we still see some cases, but interestingly, the ones that I've seen even on the citricate, it's usually not a big stone like we used to see. It's more like a gritty urine. Like the family will say they see something in the diaper or something gritty. So it may be that the citricate needed to be a higher dose, but we don't see it as much as we certainly ever used to before. It doesn't have much of an effect on acidosis. We'll try it, but it seems to really target mostly the urine, not the blood per se. So as a result of this, we think this is helpful. If you've ever had to take care of a child with kidney stones, or if you ever had them yourself, it's not a lot of fun, to say the least. This is from actually a supermarket in Baltimore. This is Miralax. You guys have Miralax here? No? So Miralax, essentially it's like a fiber powder. It tastes pretty good. You mix it in water and it becomes tasteless. And so, yeah, it's essentially like fiber. Ducalax, another kind. They're all very similar. But these fiber powders become very helpful for kids on the diet. We tell families, give it as much as you want. There's really no way you can overdose on Miralax. You just may have a large bowel movement. You can get these. It's relatively cheap in most stores. And so I'd say 80% of our kids end up on some form of a laxative, and Miralax tends to be one that they use a lot. There are some ketogenic vitamins that are now kind of starting to come on the market. There's one called Nano VM. There's another one called FlexiVites. And then a new one that's just come out is called FruityVites. These are a little bit expensive, but they're designed for children on the ketogenic diet. So they have extra B vitamins and they have vitamin D. They also have extra zinc and selenium, which I'll talk about. Most of the families like these. Do you have to use them? Probably not. They are a bit more expensive. So sometimes we'll just use a regular vitamin. But for some families, if their insurance allows, this is a nice option. Then there are, we talked about common and occasional, then there are the extremely rare side effects, which of course we heard about this morning. Even though they are very rare, we do see sometimes bruising. Every once in a while we'll hear a family talk about bruising that seems to be described on the diet from sort of the early 2000s. Pancreatitis, thankfully, is rare, a little more common if you're on valproate, but it does happen. It's happened to some of our patients. Prolonged QT syndrome seems to be most likely due to selenium deficiency, and I'll talk more about that. And then maybe as a result of hearing from Maria, I'll add thiamine deficiency as well. This was actually just reported 2 months ago, something that we had seen but had never really had an answer for. We saw it in about 2 children, and then the group from Philadelphia reported 3 children who had completely surprisingly very high serum calcium levels. And we had seen this in a few children where their calcium was very high. We sent them to endocrinology. They recommended stopping the calcium, which we did, and then eventually it got better. In these children, they actually gave them calcitonin, and you can see here within about a week, their calcium came back down to normal. No real explanation why this happens. It seems to be very rare, but if you do see a high calcium level, this is something that, again, has been reported. So people are interested in this, and again, I think thiamine should be published too. We also put into our consensus statement, in a way to try to help prevent these side effects like high calcium, how often we should be getting labs on the ketogenic diet. And this is sort of a baseline. You absolutely can get more labs if you want to. There was, again, some argument and disagreement about what is optional, but I think the basic labs should be looking at blood counts, looking at electrolytes, liver and kidney function, calcium, certainly as well getting a lipid profile to see the cholesterol and triglycerides. And then I think most of the group felt that you should be checking carnitine levels on a regular basis, because carnitine can drop on the ketogenic diet. And then if they are on anticonvulsants, keep an eye on their anticonvulsant levels. But that's kind of it. There are some centers that do check serum ketones as opposed to just urine. We don't at Hopkins, but some centers do, and find that there can be a bit more of a correlation with control. Zinc levels have been talked about, selenium levels. Now a lot of centers are starting to check for those because of the risk of a prolonged QT syndrome. You can get a lot of selenium in fish, certain kinds of nuts. It's in a lot of diets and a lot of supplements, but it's something that if it is low, you could have heart issues. So more of us are doing that than before. And then in terms of other things, renal ultrasounds, some centers do that, especially Germany. They're interested in renal ultrasounds. DEXA scans, the Philadelphia group has been doing that on a regular basis and publishing that there can be osteopenia, but most of us will do the DEXA scans if they're on the diet for long periods of time. And then some centers will do routine EEGs, depending on sort of what you're doing. That can be helpful too. Carnitine levels, again, I mentioned extra, but what do you do about that? Some will check free carnitine versus total carnitine. The British just wrote a very nice review about carnitine in the diet, and their argument was that it's really not necessary to give extra carnitine, that most of us in our bodies have enough to break down the fats. But when we asked the consensus group, the majority, 2/3, said if the carnitine levels are low and the child is fatigued or tired or not making enough ketosis, to maybe give some extra carnitine. Selenium is kind of, as I mentioned, a hot topic. There had been some papers in the early 2000s suggesting that maybe prolonged QT syndrome and cardiomyopathy could be due to selenium deficiency due to the diet. And we actually had a case about a year ago at Hopkins, which was most likely due to this as well. They reported that in general the numbers do drop, okay, from 0.95 millimoles to 0.88. This was really the only study from Helen Cross's group to systematically look at carnitine levels in their crossover study. And they said, yes, the levels do seem to drop on the ketogenic diet. We believe it's important. We don't usually give extra selenium as a supplement, but we do keep an eye on the levels, and Zahava will explain to families why fish and nuts are very important. Serum ketones are very debated. Again, some centers check ketones in the blood, some do not. Vitamin D is another interesting topic. The group out of Philadelphia looked at what happens to vitamin D levels on the diet. So does anyone know what happens when you go on the ketogenic diet to vitamin D? Yeah, so it's interesting. It goes up and then it goes down. And so most likely it goes up because now you're giving them supplements. These are children who never had vitamin D before, okay? And you're told, give them vitamin D. So you can see there's a little bit of an increase initially, and then what happens is eventually it's just not enough, okay? It just sort of drifts back down and then eventually goes sort of below normal. So the group out of Philadelphia are very strong advocates for giving extra vitamin D, more than even what we normally recommend for the diet before. In terms of other things, besides side effects, we talk to families a lot in our teaching about how to handle unexpected situations. You heard a lot about that in some of the very nice cases this morning. We tell the families to be calm about things, that we can always stop the diet and restart it if there's a problem. And then we tell them, call us, call your pediatrician, but don't jump to any conclusions that necessarily the diet is causing the issues. We saw a very nice photograph of an ICU this morning where they said no sugar allowed. We spent a lot of time telling the families about this as well. If they do need IV fluids, they should get normal saline with no dextrose. And so they're taught to say these things if they end up in an outside hospital that maybe is less familiar with the diet. We get very frequent calls from surgeons, children who need orthopedic surgery. Dentists call us and they say, can the child have anesthesia? They absolutely can. Just start the diet again as soon as possible after they're able to eat. If the child, though, becomes very sick, and sadly this happens maybe a couple times a year, and I think as we're taking care of sicker and sicker children, which seems to be what we're seeing too, there are times you just have to stop the diet. They're in an ICU, they're very sick, they have a pneumonia, they can't eat, okay? We'll talk to the family and say, let's stop the diet, we'll cover them with seizure medicines. Once they're healthy, we can put them back on the diet. This has come up to an issue. This is a nice review that one of my former residents wrote because he was getting so many phone calls from pediatricians and ER physicians and ICU doctors. He actually wrote an article for them explaining the basics of the ketogenic diet. So now when someone emails me and they say I'm an ICU doctor, I just send them this article. It makes my life a little quicker. And this is Epilepsy and Behavior 2011. I can send it to you if you would like a copy. What about long term? What happens long term on the diet? We know that the longer you're on the diet, the higher the risk for certain side effects, but not all. We know the risk of kidney stones goes up. So I really make sure that these children who are on the diet for long periods of time make sure they take their citric A. These are the children we're very alert for bone fractures, so we check DEXA scans in those children. We also know that the longer they're on the diet, the more of an impact on growth the diet can have. Out of the Toronto group, some very nice evidence suggests that once the diet stops, that the growth catches up. But we know on the diet that that can be an issue. What's interesting, and we had hinted at this before, is that even these children who had been on the diet for many, many years, their cholesterols were great. And no clear reason why. Maybe their livers just get very good at clearing it. But generally, it's not a problem long-term on the diet, their cholesterol. In our consensus statement, we had a few statements about long-term effects. There's more known now, but back in 2008, we basically said that if you're on the diet long-term, you should be doing DEXA scans. So we put that in our statement. We felt that there really was no particular side effect that should automatically lead to discontinuation. I would say if I was to do this again now, I might add cardiomyopathy, okay? We'll probably change that next time. But otherwise, most of the time, you don't have to stop the diet because of a kidney stone, okay? Or you don't have to stop for reflux. You might want to, but you don't have to. And then I think probably the most important message in our consensus was that the group felt that every child, the benefits should outweigh the risks. If the child is having so many problems and the benefits aren't worth it, probably not a good idea. The case we heard earlier today, the child who had Dravet, who just kept having all those side effects, it's a tough decision. Is the diet really worth it for all these problems? But the family thought it was. All right, so I'm going to show you a case and see what you guys would think. So this is an 8-year-old girl with Lennox-Gastaut syndrome. Has a very good response to the diet, but as I mentioned earlier today, not usually a seizure-free response. It's unlikely with Lennox-Gastaut syndrome. So she went down from 100 a day to 2 per day, and now she's been on the diet for 2 years, which is generally when we think about stopping it. She's still on one drug. Okay, you were able to get her down maybe to one drug, but she's still on one. And the family asks you, is this time to stop the diet? Yes, no? No. A couple nods, maybe. I get this every day in clinic. The second question, you say, okay, maybe let's try, right? And then she says, okay, well, what are the chances of her seizures getting worse? You heard very nice from Maria talking about the risk of recurrence. So there is a little bit of data out there on that. And then she says, okay, if it does get worse, does that mean 2 more years? Does it mean 1 more year? And then the other question they always ask is, if we keep doing this, is she going to have a heart attack? And we'll get back. There's a little data about that too. So in our consensus statement, we commented a bit. We said that generally at 2 years on the diet, you should at least start thinking about it. Okay? And some would say maybe even at 1 year, at least start weighing the option of maybe giving it a try and seeing if maybe the diet no longer is necessary. What I tell families is that the diet maybe has sort of done its job. Okay, and they can come off the diet and not have worsening of seizures. But we said very clearly that the person in charge are the parents. And I think that's always sort of true. Let them decide. Here's one story. This was actually in our local newspaper about a child with TS who is no longer a child. At the time when this was written, he was on the diet for 23 years. Now he's about 27 years. His parents tried to take him off, and his seizures got worse 3 times, and they're not trying anymore. And so we sort of keep him on the diet. This has been looked at. The Korean group did a nice study for children with infantile spasms who were spasm-free and said maybe 2 years is too long. Maria talked about this morning. Maybe we can do shorter for Fire syndrome, for infantile spasms. And so they randomized children to either a short time on the diet, okay, 8 months, or a long time on the diet, which is 2 years, and found there was absolutely no difference, suggesting that maybe tradition of 2 years is way too long, and that maybe if they're doing very well, you could take them off the diet after shorter periods of time. And the children who were in this study who came off the diet for a shorter time had less osteopenia. That's what they decided to look at, which was interesting. We decided to look a little bit into this issue in children who stopped the diet at our center. We looked at 183 children who were now off the diet. They were now about 5 years old. And what we found was that all of us, because I'm not the only neurologist in our center, we all did things a little differently. I tended to be a little quicker in taking kids off the diet. I would do it maybe over 4 weeks. My partner, Jim Rubenstein, who has since left our center, would do it over 4 months. And just, it was random. Whoever they saw that day was whoever would do things differently. And so we decided to look and see who were we likely to take the diet off quicker, who were we take the diet off slower. And it kind of made sense. The children who were still having seizures but had benefit, the children who were still on drugs, we tended to do it slower. The children who were either seizure-free or had no improvement, we were a lot quicker in just saying, stop the diet. And so when we looked to see who got worse, who had at least a 20% increase in their seizures, it was actually relatively low. It was about 14%. I know Maria had a little bit of a higher number, around 50, but in general, a significant worsening of seizures was about 14% of the kids. What we found was that most of these children still came off the diet. We just did it slowly and maybe adjusted their medicine. Some of them, we actually put them back on the diet. Most of them came back under control. 2 of them, we don't know. So it doesn't have to mean you go back on the diet if it gets worse. The other thing we looked at was, did it matter? Did taking them off the diet in 2 weeks versus 6 months make a difference? And it turned out it was no different, okay? Basically, everybody had about that 15% chance of getting worse, whether you do it in a few weeks or whether you do it in a few months. So we're definitely taking children off the diet now over about 2 months, not over 6 months anymore like we used to. Then the ultimate question, too, is can you predict? Can you tell a case like this, are you likely to get worse? She has Lennox-Gastaut syndrome. She's still having epilepsy. She's still on a medicine. So actually the data would say she is a little bit more likely to get worse. When we actually looked at the numbers, the only thing that stood out as statistically significant was the likelihood was higher in those children who were in the 50 to 99% seizure reduction category on the diet. If they were seizure-free, they were not necessarily more likely to get worse. If they had no improvement, they were not necessarily, they were bad already, they weren't going to get worse. But if they still were having some seizures, they're a little more likely. So a child like this that I talked about, I'd have to spend some time telling them, yes, it might be more like 20, 30% chance that your child could get worse, and then we have to see what to do. Who's this on the left? That is Charlie, you're right, and that's his brother. Okay, his father, Jim, sent me this photograph. He's now about 22 years old. He's in college. He shows me this photo to show that the ketogenic diet did not stunt his growth. He's as tall as his brother and sister. And so the next question his mother asked is, will my child have a heart attack when they're in their teenage years? And we used to always say, no, we don't think so. Now we actually have a little data to say, no, it doesn't happen. We did a study back a few years ago where we tried to get a hold of a lot of our kids who are now long off the diet. Some of them were in their teenage years, Charlie in his 20s. Most of them, to prove it to me, sent me photographs of them eating carbohydrates, usually very sweet ones, just to prove that they were off the diet, which I believe them. Most of them were now, again, teenagers. They'd been off the diet for about 6 years. We found most of them were eating all kinds of foods. It didn't permanently affect the kind of foods they liked. Their seizure control was actually surprisingly good. Some of them who were seizure-free are still seizure-free, like Charlie. Some of them that were better on the diet, they came off the diet and they still were doing a little bit better. We did check a lot of their cholesterols if they were interested. We sent them a lab slip and they checked their cholesterol. They were all pretty much normal, and their heights and weights had generally caught up as well. And we have time for a few questions before I think we're going to do some cases. I think we're in an era now where we're trying to be very proactive about side effects, treating them in case they happen right at the very beginning of the diet instead of just waiting for it to happen. And certainly it's rare that we stop the diet for a side effect unless it's maybe pancreatitis or cardiomyopathy. And again, I think we're really heading towards a time, I predict probably 10 years from now, where maybe we have one supplement that has everything that you could give a child that maybe hopefully tastes good to, again, prevent these kind of problems from happening. In general, I think after 2 years, we at least start bringing up the issue with families and seeing what can happen off the diet. And I think we now are much quicker taking them off it over a few weeks than we were before. And you can think about it. You don't have to, but you could probably take them off it more quickly. Thank you.
¿Alguien alguna pregunta?
Sí. Bueno, muchas gracias por su exposición. Y realmente hay algunas cosas que quisiera como preguntarle, porque creo que en este asunto de los efectos adversos hay como muchos encuentros y desencuentros que a veces se confiesan y otras no. Que entre nosotros, los que hace mucho hacemos el tratamiento y confiamos en el tratamiento. Una de esas es lo de la carnitina. Realmente muchos neurólogos indican carnitina porque sí, o muchos lo indican porque tienen ácido valproico. Otros que no son neurólogos, que son especialistas en nutrición, se quejan porque el ácido valproico no se lleva bien con la dieta cetogénica. Bueno, yo pienso que debe haber de todas las cosas esas un poco, y cada vez estoy mirando que si bien uno tiene que tener ideas generales de estos pacientes, ideas generales de la dieta, etc., creo que cada vez uno afina más la cuestión para ver las cosas personalizadamente, tanto en el paciente como en la familia, en fin, el entorno. Respecto a la carnitina, creo que hay una situación de darla así, bueno, le demos, total, esto no va a pasar nada, en fin. Y bueno, van surgiendo algunas situaciones de que el ácido valproico, el neurólogo lo necesita y lo usa. Y bueno, yo pienso que eso es una cosa muy interesante y una decisión importante. Y me parece que los dos pueden convivir, si es que uno puede, que a veces es difícil desde el punto de vista económico, tener controlada la carnitina. No sé, usted habló de suplementos y algunas cosas escribió que a mí me interesaron en forma sucesiva y no hilado. Sobre esto escribió, ¿no? Y entonces a mí se me juntaron algunas cosas y algunas nuevas que de repente le quería preguntar. Para hablar de suplementos, más que eso sería suplementar alguna o cambiar alguna cosa dentro de las fórmulas o las más habituales que usamos, o por lo menos la que tenemos acá y estamos usando muy frecuentemente. Por ejemplo, la incorporación a determinados pacientes que toman ácido valproico y van a seguir tomando, y que concretamente, por ejemplo, un caso concreto, un niño de una GLUT1 que está con acidosis y que tiene una gran capacidad cetogénica. Me parece que la capacidad de los niños cetogénica no es igual. Algunos es reconocido la energía en relación con la edad, ¿no? Y otros por otros motivos personales, como que son más cetogénicos que otros. Entonces, este chico tiene acidosis, supongamos. Tiene, aparte, ha tenido un tratamiento de ácido valproico y por lo cual después de bastante, bueno, tiene 1 año en este momento, la carnitina libre, que es la activa, ¿no es cierto?, vino muy baja, 6. Entonces, ese paciente se necesita, bueno, suplementar, obviamente. Pero yo decía por la incorporación de ciertas cosas como son el MCT oil, por ejemplo, que es uno de los pocos en una proporción que no provoque efectos adversos. Y porque es el único aceite que puede no acompañarse de la carnitina para ser procesado para la oxidación.
Podemos...
Entonces yo decía, le pregunto
Doctora.
a usted si lo usó.
Yeah. So, good question. We're very careful about the supplements, and I think you bring up a good point about that these supplements are sometimes given to everyone. Some don't taste very well. Carnitine, parents say, tastes terrible. Sometimes they're expensive. Families will say it's expensive sometimes. So we were very careful, in our consensus statement to really, that's why only a few were made mandatory. However, I think as the evidence grows, if we really think the benefits far outweigh costs or tastes, I think like citric A, I believe, should everybody. I wouldn't wait for a kidney stone. It's just not worth it. MCT actually, sometimes can cause some GI upset, so we don't, and it also can be expensive for some families. There actually was a study that said that even on the MCT diet, you can dip your carnitine levels. It was out of Toronto. They were surprising results. So it may not be completely free of carnitine issues too. But I think you're right to say, we should be very careful before just prescribing all of these. Some of the formula companies have asked. They've asked me, should we put carnitine in Ketocal? Should we put extra selenium? And I think until we know for sure, we want to be careful. Good point. Yes.
Respecto de las tasas de recaída que usted nombró, tiene una tasa sensiblemente mayor, inferior a la que mostró María. Pero quería repetir la pregunta. Si usted tiene, digamos, idea de si hay algunos síndromes específicos que se relacionen más con las recaídas, ya que usted inicialmente dijo que elegía mejor ahora a sus pacientes para iniciar en dieta y antes ingresaba inclusive algunos que hoy día sabe que tienen mayor riesgo de no mejorar. Bueno, entonces la pregunta sería si tiene alguna agrupación sindrómica respecto, más allá de que hayan mejorado o no, más de su recuperación total de las crisis.
Yeah, so the relapse rate, it's hard to know. I mean, for our study, we were very, very specific about what a relapse was, and maybe that's the difference. I mean, I think if we looked at anybody who said we had a seizure, maybe our numbers might be 50%. We were very specific that you had documented at least a 20, 30% increase above what you were having on the diet. So that's why probably we tried to be very specific. That's why our numbers may look a little bit lower. Again, the only thing that came out, we were a little bit surprised, was that 50 to 90% improvement was more likely to have a relapse. A previous study we did, we found that if you had tuberous sclerosis and you came off the diet, and actually that's that patient who was 23 years on the diet, you were more likely to have a relapse. This study we just did, we didn't find that the second time. We also found that if you had an abnormal EEG, you were more likely to relapse. And again, this second study, that didn't seem to change. So a little bit of mixed information, at least. But I look at EEG, I look at the whole case before I decide. I think, a child with Lennox-Gastaut syndrome who's had some improvement, probably a little higher risk. A child maybe with infantile spasms who is completely spasm-free, they're not going to recur. In my experience, they never recur. So it's probably everyone's a little bit different. So I do try to look at that. Yeah.
Do you si suplementa con omega 3? Así somos ordenados.
The diet, you said? No, not usually. Some families do. The question was about omega-3s. A lot of families are very interested in all of these extra supplements, omega-3, melatonin, extra fish oils, amazing lists of what some of these families are giving their kids. We usually allow it, but I don't give extra omega-3. It's enough. They get a lot of fat already, I think. So yeah. Okay, good. So after the cases, I'll come back and we'll wrap up with a little bit about the modified Atkins diet, and then finito. See? Okay.
Muchas gracias.
Okay.